want to make sure that we give you both sufficient time. So is it okay? We'll start, and I know people are still logging on. So to all of you who are joining us and online, thank you for coming back to our virtual Grand Rounds. This is now about 6 weeks into our relaunch of Grand Rounds in this virtual setting, and I'm just so pleased. We've had spectacular speakers throughout this revised reboot of Grand Rounds, and frankly, today is, again, no exception to exceptional speakers. And what I think is unique about the theme of today is we talk a lot about translational science, that is moving laboratory work into the clinic. But I think translation is also in the world of population science, that is epidemiology and health services research, and leveraging that to improving the outcome for our patients. And I think both of our speakers really exemplify that commitment. So our first speaker is Dr. Melinda Irwin. As many of you know, Melinda is the Associate Dean for Research at the Yale School of Public Health, Professor of Epidemiology, as well as the Associate Cancer Center Director for Population Science and our leader for cancer prevention and control. And over the past 2 decades, Melinda has been a leader in intervention studies, leveraging what we know about diet and lifestyle and putting it into place within the context of clinical trials to not only improve patient outcome, but actually use the biospecimens to really understand cancer biology and cancer therapy. So Melinda will share with us our work on the LEAN study. So Melinda, thank you.
Great, thank you. So I'm gonna share my screen, and can you see that?
Yes.
Good, okay, great. So thank you for inviting me today to present the LEAN study to you, which is an R1 trial we have in progress right now. Tara Sanft and I are co-PIs on this this study, and it's a study of women with breast cancer receiving chemotherapy. And we're going to talk to you today about how we are keeping them healthy and active during the COVID-19 crisis. So just some background, a rationale for why we're studying obesity and cancer outcomes. We know that there's been a 29% drop in cancer mortality rate since the peak in 1991. However, what's unknown is if this decrease in cancer mortality will be offset by a rise in obesity. We know that 40% of adults have a BMI greater than or equal to 30, which is how we define obesity, and that this is a 6-fold increase in obesity rates since the 1970s. 14 cancers are associated with obesity, and 13 cancers are associated with low physical activity levels. When we look at this graphically, this is a slide from a publication in JAMA 2 years ago about all-cause mortality in the United States. But what's really important to note is that over 500,000 deaths per year are associated to poor diet. And then when we look at high body mass index, another 400,000 deaths associated with high BMI, and then low physical activity accounts for about 100,000 deaths. So collectively, what we call energy imbalance explains over 1 million deaths per year. So this is really important that we look at energy balance for cancer prevention and control, but also for the other causes that many cancer patients die of, such as cardiovascular disease. So as I mentioned, there's 14 different types of cancer associated with obesity. Most of the research has been done in breast and colorectal cancer, so many are not aware, clinicians and patients, and the lay public are not aware of all the other cancers that are associated with obesity. So I really hope over the next decade, there's a lot more research done into these other cancers. I mentioned physical activity is associated with reducing the risk of 13 cancers, and it's also associated with reducing cancer mortality rates. Once again, most of the research has been done in breast and colorectal, but you can see here there's a number of cancers that risk is attenuated with physical activity, and the relative risk is about 30% of protection. So because of this large body of observational evidence over the past 2-3 decades, we do have guidelines, dietary guidelines and physical activity guidelines. The current dietary guidelines really focus on a healthy eating pattern across our lifespan, really focusing on eating a nutrient-dense diet and limiting added sugars. As you might now know, the food labels on all the foods we purchase do pull out the added sugar, so it's really important to look at that on our food labels. The physical activity guidelines focus on reducing our sedentary behavior and then trying to do about 2.5 hours per week of a moderate intensity activity or 75 minutes of a vigorous activity, as well as 2 times per week of strength training. These are challenging guidelines and recommendations to meet. Most everyone knows it's good to eat a healthy diet and to exercise. The challenge is being able to do them. And that's where a lot of the research is focused on behavior change and how to get people to follow and adhere to these guidelines long term. The mechanisms we know, this is focused on breast cancer, but we know especially in women with who are postmenopausal, the higher amount of body fat we have, the higher estrogen levels due to conversion of androgens to estrogens via the aromatase enzyme. And this leads to a cascade effect of higher insulin levels, inflammation levels, growth factors, and in turn leads to cell proliferation and leading eventually to breast cancer. Earlier, in the late 90s and the early 2000s, one of the largest trials ever done was by Ann McTiernan and colleagues out at the Fred Hutch in Seattle. I was fortunate to be able to do my postdoc work with her and contribute to some of her trials. This is a study among women without cancer. It was a large sample size of over 400 women where they were randomized to a diet intervention, exercise, or the combination. And the point here is to simply show that there can be large effects on these biological markers measured in the blood with about a 5% weight loss. And you can see significant clinically meaningful decreases in insulin levels and leptin and CRP. And we know that these markers are related to cancer risk and prognosis, and therefore they're modifiable with lifestyle interventions. So based on that work and others, we over the last decade have been doing trials here at Yale of lifestyle behavioral interventions. And one of our most recent studies was the LEAN study that was done among women after completing treatment for breast cancer. So they had completed chemotherapy or radiation therapy, and we randomized them to either a telephone or in-person weight loss intervention that involved 11 counseling sessions by a registered dietitian, Maura Harrigan, or a usual care group. And as you can see, within 6 months, they were able to lose about 6% body fat, and it was no different from telephone versus in-person. And most importantly, this weight loss led to significant decreases in CRP of 30%, as well as a 10 and 15% decrease in insulin and leptin. So preliminary findings that weight loss via exercise and healthy eating can change these surrogate markers related to cancer risk and mortality. So what we don't know is potential indirect effects of energy balance on cancer outcomes, in particular treatment adherence. So we're really intrigued by the question of whether obesity, exercise, and nutrition impact treatment adherence. And why this is important is because of a publication about 5 years ago showing among a number of different types of cancer, breast, ovarian, lung, colorectal, that chemotherapy completion rate, or what we call as relative dose intensity, varies. And in fact, there's a reduced RDI of about 20% to 80% among these different cancer types. And it's more common in older individuals as well as those with obesity. As you can see here in this table, patients with a higher body surface area, 42% had a reduced RDI compared to those with a lower body surface area. So observational findings that lifestyle behaviors might be associated with treatment adherence. And here at Yale, Ilana Uziskin, who's just completed her medical degree here at Yale under the mentorship of Tara Samt, they did an epic review of 243 women who were given neoadjuvant chemotherapy at Smilo. And Ilana also followed up with a telephone survey to assess physical activity levels. And interestingly, they found a 56% of these patients had a reduced RDI, defined as a dose delay, and the average delay was 12 days, or a dose reduction. So collectively, over half had a reduced RDI. The most common reasons were myelosuppression, infection, neuropathy, and fatigue. And then when she looked at BMI, she found that patients with a PCR had a lower mean BMI than those with residual disease, and that exercisers were more likely to complete chemotherapy than non-exercisers. So very exciting preliminary data that, once again, these modifiable behaviors could impact treatment adherence. So building on those findings, Dr. Sampton and I wrote and submitted an NCI R01 and were funded to do a randomized controlled trial among 250 women diagnosed with stage 1 to 3 breast cancer at SMILO and who will receive chemotherapy. And then we randomized them to either the lean intervention, which is the whole first year after diagnosis, versus referral to the survivorship clinic. What's innovative about this trial is it's the first to our knowledge where the primary endpoint is chemotherapy completion rate, as well as looking at endocrine therapy adherence. We're also looking at treatment toxicity, biomarkers, body composition, and Leah Ferrucci, who's an assistant professor in YSPH, is looking at the gut microbiome changes to this intervention. So schematically looking at this, we recruit women and we screen and consent them. Pre-COVID, they'd have a baseline clinic visit where we would collect DEXA, bloods, and a stool sample. We then randomize them to intervention or usual care with a post-chemo clinic visit 1 year and 2 years. So even though the intervention finishes at 1 year, we continue to follow them for an additional year to look at maintenance of these behavior changes and the impact on these outcomes. And the urine is collected to look at AI, aromatase inhibitor adherence. So some preliminary findings, we are still recruiting for this trial for another 1.5 years. Our goal is to recruit 250 women. We've randomized 92 to date, but we started recruitment 28 months ago, back in January 2018. So over the past almost 2.5 years, there have been over 3,000 women diagnosed with breast cancer at SMILO. If we follow this middle column here, we are focusing on stage 1 to 3 patients who are receiving chemotherapy. So 20% of the patient population is stage 1 to 3 receiving chemotherapy. We've been able to screen 35% of that population. And then what is really exciting, 43% of those that we screen were able to consent. This is a higher consent rate than our other trials. We then randomize them to intervention and control. The reason we think we're consenting at a higher rate is because that we are approaching the entire population of women who are stage 1 to 3 breast cancer receiving chemotherapy, rather than it being more of a selection bias and those who are interested approaching us. So by approaching the entire population, we're able to screen and consent a larger percent. And this in turn has led to a very high recruitment of underrepresented minority women. We have a 33% of our 92 women are Black, African American, or Hispanic. So we're really proud of that number. That exceeds the rate across the state of Connecticut that are underrepresented minority. We are continuing to do more to increase this number even more, but we're really proud with that enrollment rate of underrepresented minority women. We are open at 13 SMILO care centers, and we've enrolled from 10 of them. The latter 3 were open a little bit later, so we're hoping to enroll some patients from that site. But really proud of our effort and grateful to all the care center clinicians and support staff there in recommending our study and referring their patients to our study. So a little bit about the challenges since COVID-19. Recruitment continues. So we're able to do this because we're intervening via the telephone rather than in person. When our previous trial that I mentioned, the LEAN study, where we did it post-treatment and we compared in-person versus telephone, we showed that telephone was as effective in delivering the intervention. So pre-COVID, we would do the counseling sessions during the chemotherapy regimens, chemotherapy infusions, and or on the telephone, and now we've gone fully telephone. The challenge has been that we're recruiting at a slower rate because before COVID, about 24 patients per week were diagnosed and scheduled to receive chemotherapy. versus now only about 13 patients are diagnosed and receiving chemotherapy. Obviously, that's because the screening, mammography, and other screening activities are put on hold, and so that's leading to fewer women being diagnosed. Also, some chemotherapy regimens have changed to dose-dense Taxol, so that'll be interesting for us to examine the impact of the intervention on different chemotherapy regimens. Are there more side effects with the dose-dense than the other types of therapy? And will there be a effect modification of our intervention by treatment regimen? So 70 of the 92 enrolled thus far have completed their chemotherapy, so they won't be impacted by COVID as far as our data analysis goes. However, 22 of those enrolled were enrolled during COVID or were in the study receiving chemo during COVID. And 9 of the 22 regimens have already been changed because of COVID, primarily because of limiting the number of visits into the hospital. So that'll be interesting to see how that affects our outcome results. So as I mentioned, post-COVID, we are able to continue to screen, consent, and randomize via the telephone, collect questionnaires via our online link, our intervention counseling sessions delivered via the telephone, and we are able to look at our primary outcome of relative dose intensity via EPIC. But because the hospital is closed, we're not able to collect blood right now, nor DEXA scans or collect the stool sample. Those are our secondary endpoints, and we hope to get back into collecting those. It just might be a reduced sample size than what we originally proposed. So I mentioned that there are 13 different chemotherapy regimens. The way we are analyzing our primary endpoint is we look at the total dose delivered over the actual planned dose that was prescribed before they began treatment. And we look at this for each drug separately by person, and then take an average and then summarize that by randomization group. And then we will then compare the two randomization groups to see if the intervention impacts chemotherapy completion rate. Let me just tell you a little bit about our intervention. Our women are randomized to nutrition or exercise intervention. This is led by 2 exceptional registered dietitians who are also certified specialists in oncology. Maura Harrigan and Courtney McGowan are exceptional in their delivery of this. We adapted the intervention from the diabetes prevention program as well as the dietary guidelines and the exercise guidelines. We do 16 sessions of roughly 30 minutes per session over the first year. As I mentioned, they're either done in person during the chemo session or over the telephone. And we also developed a home-based exercise program that I'll tell you about a little bit more on the next slide. And then they're also referred to the survivorship clinic. The usual care group, we go a little bit above and beyond what is usual care here at Smilo. They have a consult with the Smilo Care Center RD upon request. We provide them a 60-minute counseling session and then also referral to the survivorship clinic. So there are 16 sessions over the first year. The way they're delivered is the first 4 are really skill building. We also developed a lean recipe book specifically for women receiving chemotherapy for breast cancer based on side effects of chemotherapy. The sessions 5 through 11 are really about them owning the new skills and knowledge and being able to make these changes. And then the latter sessions are really about maintenance of those behavior changes and sustaining them. The exercise goals follow the recommended guidelines. We developed an online videos for our strength training program. We also give them a Fitbit that encourages them to get to 10,000 steps per day. So some challenges due to COVID. We're all experiencing this, so this is not necessarily unique to cancer survivors, but the food-related challenges are the limited trips to the grocery store, and then the limited selection of foods at the grocery store. So our counselors have really focused on educating them on stocking up on frozen and canned vegetables and reviewing the recipes to incorporate the frozen and canned vegetables, limiting the portion size, continuing to log what they're eating. We know from many trials that when you log your behaviors, what you're eating and exercise, that's the #1 predictor to behavior change and sustaining that behavior change. The other challenge is that being homebound means you have access to your kitchen all day long. So the counseling sessions have really focused on how to maintain healthy eating or continue to eat healthy, even though your kitchen is calling you all day long. Exercise-related challenges are that the gyms are closed, and many of our participants have a fear of leaving the house. So the counseling really focuses on the home-based exercises, as well as some other ways to get their exercise in. There's also unique concerns to breast cancer survivors, and this isn't COVID related, but in general, many, and it's not necessarily specific to breast cancer, but many have a fear of food and that something they ate may have caused their cancer. And there is so much misinformation on the internet. And so a lot of the early counseling sessions really focus on educating them, hearing, what their concerns are and listening to them, but also really educating them on what is the correct information and also appropriate websites. They also, especially now during COVID, while they're caring for themselves, they're very much caring for others. And so it's a challenge of them taking that into consideration. So to date, I mentioned that 46 have been randomized to the intervention. 26 are mid-study, but among the 20 that have completed the year-long intervention, there's been 95% compliance to the 16 sessions. So we're really proud of that adherence rate. We'll now examine the changes in exercise diet, as those obviously will impact our outcome. Some of the comments from women randomized to the intervention is that it never occurred to them to pay attention to eating habits during treatment, and that a large part of the recovery is due to the lean exercise and healthy eating. And the last quote I really appreciate here is, I wasn't sure what to expect when I started the study, but now I know it was life-saving to me. So a lot of what we discuss with our research team weekly, is it the changes in nutrition and exercise that might improve chemotherapy completion rate, or is the extra attention and supportive care given to them, is it really that is the mechanism, or is it the combination of the two? So we'll drill down a little bit more on that once we are able to analyze the results. So future directions, just 2 more slides here. We're going to continue to recruit for this trial through next December. So care center doctors and clinicians, if you have patients who are about to receive chemotherapy, let us know. We do go through the EPIC pre-screening. Michelle Duba has been instrumental in that. And so she sends emails to the clinicians to alert you. So be on a lookout for those emails. We were also awarded an NCI diversity supplement to Margaret Pichardo, who's completing her PhD here at Yale in the School of Public Health, where she's doing really important qualitative interviews of African American and Hispanic women with breast cancer. She's done 15 qualitative interviews, and she's also done 10 interviews with clinicians regarding barriers to exercise and eating healthy. So those results will be really important and set the stage for our future studies. We are also planning to submit an R01 where we would like to take our intervention into the Smilo Care Centers as a standard of care and do a implementation science study where the unit of measure is the care center rather than the participant. And so randomize half of the care centers to the intervention versus the other care centers to control, to look at this implementation trial design in cost effectiveness and other outcomes. We hope to submit a PO1 to expand our intervention to other cancer types. And then lastly, this last year, we submitted a P30 application for Nutrition and Obesity Research Center. And what was really exciting to learn is that there's over 68 faculty from across the Yale campus who are doing obesity-related research. And 22 are Cancer Center members. And there's a significant amount of current direct funding among these faculty, over 28 million. So we really want to continue to network with this group of faculty and pursue some team research opportunities, some team science in this as well. We hope that the research that we and others have done will motivate the clinicians to recommend and refer patients to the Yale Cancer Center Survivorship Clinic that Dr. Sampt leads. Lastly, I just want to highlight an R25 grant we have for junior faculty from around the country and the world who can get trained on energy balance and cancer research. This is a week-long workshop that we host here at Yale, It's transdisciplinary, where we have basic scientists, clinical scientists, and population scientists working together to really, we work with them on their grants and help them and submit them and get them funded as well. So if you have fellows or junior faculty or you yourself are interested in this, please reach out to me and I can share more information. So in closing, I'd just like to acknowledge the study participants and the referring clinicians who've been really instrumental in this trial and all our previous studies. I'd like to shout out some of our team. Of course, Tara Sampt, I couldn't do this without her collaboration. Brenda Cartmel, who's really been critically important with our regulatory aspects, data management, has been really wonderful. I mentioned Maura Harrigan and Courtney McGowan, who are registered dietitians, and Michelle Zupa, who's been critical in helping us recruit patients, as well as Tai Nguyen as well. And Leah Ferrucci, who is overseeing the microbiome analyses and some other dietary-related analyses. So thank you all.
Melinda, thank you. That was a fabulous talk, and thank you for all that you're doing, both in understanding the effect of these factors on cancer outcome and